Dr. Mansell, good morning.
Good morning.
You've been following this Medicaid expansion issue the last several years. What are your thoughts on?
The problem is that regardless of how we label it or how we rearrange the deck chairs on this particular ship, it's still Medicaid. And Medicaid, typically pays less than the cost of care to a hospital. And, as a physician, I at least have the discretion to be able to balance, whether or not I'm going to see a Medicaid patient based on the business model and everything. But hospitals are sort of hostages to the cost of bricks and mortar. While I understand they're starved for revenue because they have both uncompensated care issues, expanding the number of Medicaid patients is like that horrible joke that we've heard, hey, we lose money on every sale, but we'll make it up in volume. Because, in fact, they're only getting paid, like 89 cents for every dollar of the cost of them. I'm not saying 89 cents on the dollar of what they normally charge a retail patient. I'm saying on what they have to pay to, let's say, buy a drug or a Band-Aid. They still don't get reimbursed enough by Medicaid. So it just accelerates the cost shifting to all of us who actually do pay for our health care.
It makes our insurance premiums go up as a result.
Exactly, because the cost of health care goes up. So that when we tip the scale even further, right now in the United States, about 50% of health care is purchased by the government using below-cost reimbursement with Medicare and Medicaid. If we cross in where it's 55% or 60%, the remaining people who actually pay for the health care, we have to cost shift onto those people for the hospitals to stay open.
Doctor, what do you see as the option? Obviously, we have people who are indigent, who are not able to pay for health care. Well, what do you think? How should we address that as a state?
A couple of things. Firstly, ironically, it's the programs like Medicare or Medicaid that have driven up the cost of health care so high that a regular job, no longer an employer, can't even afford to purchase health care because of the presence of Medicare and Medicaid. So you get caught in this chicken and egg argument as if we didn't have Medicare and Medicaid, instead of a $900 or $1,000 a month premium, you'd be looking at a $400 a month premium or $500. Even if we just took the sheer math of half of the country is on, or half of the healthcare in the country is purchased by under-reimbursing government programs. So the first step would be, we have to transition away from that. The key facilitating step for that would be to go the opposite direction of where we've been going. Every state that has had a Medicaid expansion has found that more people showed up than they anticipated, and it's been a budget buster for them. They're looking at it, scratching their heads, going, I don't know where we're going to get the money for this. But more importantly is every time we've intervened in the insurance industry for health care, it drives up the cost. In Wyoming, before you can sell any insurance policy for someone for health care coverage, the legislature has, like every other state in the union, has added mandates that special interests have tacked on to it. So they're like, in this state, 32 mandates for healthcare insurance. And they have to cover things like podiatry and chiropractic and behavioral health and addiction medicine. What this does is every time we add on one of these features, the actuary for the insurance company has to figure out, okay, what would this cost and how do I spread this risk out among policyholders? If you could order your insurance in a cafeteria plan with no mandates, much like when you order a car, you design a car, you order an online computer or something like that, your insurance would be a heck of a lot cheaper. If I said, hey, I don't need obstetric coverage, I'm 54, and as a physician, I know I never want a liver transplant or a heart transplant, I just wouldn't want to go through all that. You could waive certain things you don't want and just say, look, I want a $5,000 deductible, I'll do a 20% copay. You could design your own plan, and much like a payment buyer for buying a car, you could decide, okay, that's a premium I could live with. Then you'd see insurance rates come down. Probably, it wouldn't surprise me if they came down 70%. Because we wouldn't be forcing everyone to buy a Mercedes 500 SL convertible, which is what the Affordable Care Act basically is making us do. We all have to buy the most expensive health care there is.
Right. And boy, when you start getting into that health insurance marketplace, it's not really a marketplace. I mean, a marketplace is what you just described, Doctor, where you can order the insurance coverage that you want instead of being forced to pay for things that you don't need, like obstetrics care for men. Why should a man have to pay for that? He's never going to use it.
And the other interesting thing here is I was just on a business trip last week. I'm watching the news. I'm an old guy. I watch the news a lot. And there's a commercial for LASIK. LASIK, the corrective eye surgery, where they go in and improve your vision. And they were advertising it for $299 an eye. Well, 15 years ago, when it first came out, it was like $2,000. Okay, the difference in this particular healthcare product is that there's no government program that's got its thumb on the scale of the free market. The free market for people who do LASIK, which is doctors and nurses and very expensive equipment to do LASIK, by the way, had a free market opportunity to compete, and therefore there's not been cost shifting, there's not been artificial mandates on it, and now it's much less expensive. And the same trend even exists in plastic surgery. There are enough plastic surgeons out there. People make a value-based decision on what they want to do with their money, and so with the competition, the cost of plastic surgery has come down over the years. That's the dynamic of a free market. And so more government really has not been shown to ever help control costs. It's always been a free market to help control that kind of cost.
Absolutely. Competition and innovation is what lowers costs. The other problem I have with the whole government intervention is we're broke. The most conservative estimates say that we're $18 trillion in debt. $18 trillion. How in the world can we justify spending more money on programs that just don't work?
Well, the real sad thing here is by offering these benefits today, I know some of the features of this new and improved version of Medicaid include where they have like a monthly premium and maybe the copays will go up, which I support copays going up because we have some people who, if you were to go ask an emergency room doctor in, let's say, Riverton, they'll tell you some people come to the ER 23 to 28 times a month. There's no disincentive because the copay is either $2 and they can say, well, I'm just not going to pay it, and there's nothing we can do about it because of certain federal laws that say we have to see anyone that shows up to the emergency room, even though they're obviously with a brief cursory medical examination, they don't have a true emergency. We have people who overutilize. So I do support that, but saying that we're going to fix this by having them have a $25 a month premium pay-in, if you're an able-bodied adult and you could get a job where you had part of your compensation goes to a $900 a month premium, or you could just not go to work and you only had to pay $25 a month, people are like animals. We're going to take the path of least resistance. And so when you create one of these benefits programs, people will take advantage of it. And we don't have at least we've historically not demonstrated that we have the ability to know when to cut off a benefit. I don't know of any large benefits program in the United States that's actually been shut down in its history. We still have the Strategic Helium Reserve, and I don't remember seeing any helium-powered blimps in Iraq, my 3 terms there. So we just don't have the ability to shut down government programs. Once we expand Medicaid, you have to ask yourself, which should be harder for the legislature to do, not initiate a benefits program or turn off an existing one that had 50,000 people in the state on it.
About how many people are taking advantage of Medicaid in Wyoming now? Do you know a round number?
The numbers in the annual reports the last few years have been between like 77 and 83,000-ish.
And what are they proposing with this Medicaid expansion to take it up over 100,000?
They're anticipating 17,000 additional covered lives, but the issue with that is I think it was in the Chicago Sun-Times today, Illinois was anticipating 200,000, 400,000 people they were going to cover, but the actual number of people who registered for it was 58% higher than that.
My goodness.
Colorado, similarly, had a fairly large number of people they thought were going to be covered, and I think they overshot that one by 400,000. I want to be quoted on that. The problem with this is that we can't adequately estimate it. No state has done it that way so far. And one other phenomenon that we have seen in the Midwest, I know I live in the West now, but I was in the Chicago suburbs for 14 years, was we'd actually see people come from other states where they didn't have the resources to support the Medicaid program. So one of the dirty secrets of Wisconsin that was known to physicians and nurses there were over 10,000 people who actually lived in New Jersey, New York, and Pennsylvania who commuted to Wisconsin, and they would share like an apartment address or something so they could get free health care under the Wisconsin Medicaid program.
Wow.
And I would say in the last 18 to 24 months, here in Wyoming, I have seen people who were from California, from Brooklyn, from Oregon, from Washington State, from New Jersey. They moved here for health care, basically, because I'll typically, as part of your social interactions with your patient, you go, hey, what brings you to Wyoming?
Sure.
It wasn't work, and it wasn't family. It was, you guys have nice hospitals out here, and you've got a nice program. It's sort of the opposite of the 49ers when people move to, California to dig for gold, or they move to the Bracken to work in the oil patch. We're starting to see a phenomenon in the United States of people actually leaving an area where they may have an intact program, but the hospitals are burnt out because they're overutilized, because they don't have the cash flow to actually maintain facility. You don't have to have a PhD in healthcare economics to know when you walk into an emergency room that looks run down and the staff looks exhausted, and you have to wait 6 hours to get in.
Doctor, the sponsor of the Medicaid expansion bill in the Senate is your own Senator Michael Von Flattern. Have you spoken with him about your concerns?
Mike and I are in Rotary together, and he's always been very cordial and open to me presenting this side of the argument. And I think Mike's a straight shooter. I think that on this particular policy, I think he's somewhat misguided, sadly. When we talk about them, they said, we had 2 hours of public hearing this year and 2 hours of public hearing last quarter and everything. I don't normally speak up quite this bluntly about things, but I have 27 years of in the trenches experience on the topic. I would say that most physicians I work with are like-minded. It's just a little bit politically risky because if you oppose Medicaid expansion, it makes you look like you're a Scrooge. My concern is the what I call fourth dimensional compassion. There are obviously people in the state who need the support of Medicaid. There's no doubt. I could probably name 10 people right now, if it weren't a violation of their confidentiality, that obviously deeply need the program and it serves them so well. But if we keep expanding the program, in 10 or 15 years, I worry that we won't have the resources to support those people who desperately need the program. We're just going to run out of resources and money. I'm trying to think of where are those people going to be 20 years from now if we don't become more judicious in how we implement the program.